class today is on macrolides. Macrolide is a narrow spectrum antimicrobial agent. Acha, what do we mean by broad spectrum and narrow spectrum antimicrobial agent? Broad spectrum antibiotics is the class hoyeche. তো ব্রড স্পেকট্রাম আর ন্যারো স্পেকট্রাম অ্যান্টিবায়োটিক মধ্যে পার্থক্য কি আছে? জেনারেলি ব্রড স্পেকট্রাম অ্যান্টিবায়োটিক they act on both gram positive and gram negative bacteria. They are called broad spectrum antibiotic. Now these macrolides, they are more active against the gram positive bacteria and include some gram negative bacteria in their antimicrobial spectrum. So the structure of the macrolide, basically these macrolides, they always include a macrocyclic lactone ring. This is the macrocyclic lactone ring which is included in the macrolide structure. So these are antibiotics having a macrocyclic lactone ring with attached sugars. Now the first prototype drug in the macrolide antibiotic group is the erythromycin. Erythromycin is the first member that was discovered in the year 1950s, and later on other drugs were included in this category that included Roxithromycin, Clarithromycin, Azithromycin and Spiramycin. Now coming to the Erythromycin, this drug is isolated from Streptomyces erythraeus in 1952. So it's of biological origin derived from bacteria. Since then, it has been widely employed mainly as an alternative to penicillin. Penicillin, the antimicrobial spectrum of erythromycin is more or less similar to penicillin, and in places where penicillin cannot be used, erythromycin was used as an alternative. Water solubility of erythromycin is limited and the solution remains stable only when kept in cold. Now again, erythromycin is primarily bacteriostatic at low concentration but becomes bactericidal at higher concentration only to certain organisms. Now what do we mean by bacteriostatic agent and bactericidal agent? Anyone? Difference between the bacteriostatic antimicrobial agent and bactericidal antimicrobial agent? Bacteriostatic antimicrobial agents, they mainly inhibit the growth of the organism, while bactericidal antimicrobial agent, they kills the organism. So erythromycin is bacteriostatic at lower concentration but becomes cidal for certain bacteria only at higher concentration, and this cidal action depends on the organism on which it is acting and the rate of multiplication of the organism. Now how it acts? Basically, the susceptible gram positive organism, susceptible gram positive bacteria, they accumulate erythromycin intracellularly. So they are accumulating erythromycin intracellularly by active transport, and this basically is responsible for their high susceptible to the antibiotic. As gram positive bacteria, they are able to accumulate erythromycin intracellularly, hence gram positive bacteria are more susceptible to the antibiotic. Activity is enhanced several fold in the alkaline medium because the drug is more in non-ionized form and easily permeable in the higher pH. Now mechanism of action, basically erythromycin, they inhibit the bacterial protein synthesis. Okay, they are inhibiting bacterial protein synthesis. How? So erythromycin acts by inhibiting bacterial protein synthesis. It combines with the 50S ribosome and inhibit the translocation process. Now these are basically schematic diagram showing the protein synthesis. This is a mRNA strip to which 50S ribosome and 30S ribosome is bind. These C3 and C4, they represent the codons. Accordingly, the protein will be synthesized as per the codon. Now, what happens? This is a peptide chain, and in the codon, in the mRNA ribosomal complex, there is a P site called peptidyl site. There is a site called peptidyl site, and there is a phase called acceptor site. Now, this peptide chain is bound to the P site of the mRNA ribosome complex via the help of T-acyl RNA, and the nascent amino acid that will be bound to the growing peptide chain, they bind to the A site via the T-acyl RNA. Now, what is the function of the T-acyl RNA? They are complementary to the codon. So, which amino acid will bind to this codon, will bind to this A site, depend on the T-acyl RNA, and that is complementary to the codon. So, to this A site, the nascent amino acid, they bind. Now, what happens after binding of the amino acid to the A site? This peptide chain is basically bound to this nascent amino acid, and the peptide chain grow up. After that, this ribosomal complex move forward, and the A site becomes the P site, and the A site is free to accept the next amino acid. This part is called chain elongation, and this is called translocation. Now, what happens? These macrolides, they bind to the ribosome, 50S ribosome, and inhibit this translocation process, and hence they are responsible for termination of the peptide chain elongation process. Now, coming to the antimicrobial spectrum of the macrolides, it is narrow spectrum, includes mostly gram-positive bacteria with a few gram-negative bacteria, and their antimicrobial spectrum overlaps with that of penicillin. Now, erythromycin is highly active against gram-positive cocci, Streptococcus pyogenes, Streptococcus pneumonia, Neisseria, gonorrhea, Clostridia, Corynebacterium diphtheria, Listeria. But penicillin resistant organisms are now seen to be resistant to even erythromycin. In addition, Campylobacter, Legionella, Brunhamella, Gardnerella, and Mycoplasma, which are not affected by penicillin, are sensitive to erythromycin. Haemophilus ducreyi, influenzae, Bordetella pertussis, Chlamydia trachomatis, Streptococcus viridans, Neisseria meningitidis, they are moderately sensitive. Enterobacteriaceae, anaerobes including Bacteroides fragilis, are not inhibited by the erythromycin. All cocci are basically the mechanism of developing resistance. All cocci, they develop resistance by actively pumping out the antibiotic erythromycin. Resistant Enterobacteriaceae, they also possess erythromycin esterase enzyme that is responsible for the resistance to the erythromycin. Alteration in the ribosomal protein, ribosomal binding site for erythromycin is also one of the mechanisms. All these three mechanisms are plasmid-mediated, and it can also be by chromosomal mutation leading to change in the 50S ribosome. Now, an organism that is resistant to erythromycin, so cross-resistant to other macrolides also. Again, the organisms that are resistant to erythromycin can show cross-resistance with clindamycin and chloramphenicol. Why? Because of their proximity of the binding site to the ribosome. Now, pharmacokinetics, Number one, they are acid labile. As a result, they are available in enteric coated formulation so that they can be protected from the gastric acid. Number two, food delays the absorption of the drug. So, food delays the absorption of drug by retarding gastric emptying. Distribution, they are widely distributed in the body. They enter the cell, crosses serous membrane, abscess and placenta, but they do not cross the blood-brain barrier. They attain higher concentration in the prostate vein, 70 to 80% plasma protein bound. They are primarily excreted in bile. Renal excretion is minor. Drug can be given in renal failure patients even. Plasma half-life 1.5 hour, and but the effect lasts longer because of the higher tissue concentration. Now coming to the side effects. Side effects are milder, generally gastrointestinal, that include epigastric pain, mild to moderate, particularly in children on oral ingestion. Diarrhea can be seen. And now why this epigastric pain is seen? This is because erythromycin acts as an agonist to the motilin receptor. These motilin receptors are present in the upper gastrointestinal tract and is responsible for the gastric emptying. As this act as an agonist to the motilin receptors, it increases the gastric emptying time, and the side effect, epigastric pain, is noted due to the cramps in the upper gastrointestinal tract muscles. Very high dose of erythromycin have caused reversible hearing impairment. Hypersensitivity reactions are rare but can be seen, that include fever, rashes and other allergic manifestations. Coming to the interaction, this drug erythromycin, it inhibits CYP3A4 enzyme. As a result, rise in plasma levels of theophylline, carbamazepine, valproate, ergotamine and warfarin is seen, and the drug can show severe QT prolongation leading to torsades de pointes if co-administered with terfenadine, acetamidol, cisapride. Now coming to the uses of erythromycin, we are dividing it into three groups. Number one, as an alternative to penicillin, where penicillin are the drug of choice, where penicillin cannot be given or the organism has become resistant, there we can use erythromycin. Number one, streptococcal pharyngitis, tonsillitis, otitis media, community acquired pneumonia caused by pneumococci and Haemophilus influenzae. Here erythromycin can be used as an alternative to penicillin. Again, it can be used for the prophylaxis of rheumatic fever and subacute bacterial endocarditis. Now, which penicillin is used in rheumatic fever prophylaxis? Is long-acting penicillin, benzathine penicillin. So, it is an alternative drug for prophylaxis of rheumatic fever and subacute bacterial endocarditis. However, many bacteria resistant to penicillin are also resistant to erythromycin. Diphtheria. Diphtheria is a drug of choice, which is a diphtheria antitoxin. Diphtheria antitoxin is the drug of choice to deal with the disease, but for the eradication of organism, erythromycin can be an alternative to penicillin. Coming to tetanus, it can be used as an adjuvant therapy to the antitoxin and toxoid therapy. Syphilis and gonorrhea as an alternative drug, but relapse rate are higher. Leptospirosis, where patient is allergic to penicillin. Now, as a first choice drug, number one, atypical pneumonia caused by mycoplasma pneumonia, where penicillin is ineffective. Rate of recovery is increased. Whooping cough. In whooping cough, erythromycin is a drug of choice, 1 to 2 week therapy, but the effect on the symptom depends when the treatment is started. Like when the patient is in incubation period, if we start the therapy, then the next stage can be aborted or the severity of the next stage can be decreased. if the drug is started in the convalescent period, that means between 1 to 2 weeks. In that case, patient will develop the symptom, the classical whooping cough, but the severity and duration can be decreased. If the drug is started when the classical croup has started, that means in between 2 to 4 weeks, then generally the drug has got no effect on the symptom, duration and the severity, but we can eradicate the disease. And in the convalescent stage, drug which croup gradually resolves is not modified. Coming to the chancroid, in the chancroid, erythromycin is one of the first line drug as effective as single dose of azithromycin or ceftriaxone. It is also used as a second choice drug in Campylobacter enteritis, where fluoroquinolone is the drug of choice. In the Legionnaires' pneumonia, where azithromycin and ciprofloxacin are preferred. In the Chlamydia trachomatis infection of the urogenital tract, where azithromycin single dose 1 gram is the drug of choice. Penicillin resistant staphylococcal infections, the use has decreased because of the growth of erythromycin resistance. Now coming to the newer macrolide, erythromycin is a prototype drug. The problem with the drug is it is acid labile, number 1. So in an attempt to overcome the limitation of erythromycin, like number 1, narrow spectrum, gastric intolerance, gastric acid lability, low oral bioavailability and tissue penetration, newer macrolides have been synthesized, which include Roxithromycin, Clarithromycin, Azithromycin. Coming to the Roxithromycin, it is more acid stable, semi-synthetic, longer acting macrolide. Plasma half-life around 12 hours, twice a day dosing can be done. Antimicrobial spectrum closely resemble to that of erythromycin, but more potent against Branhamella, Gardnerella and Legionella, and less active against Bordetella pertussis. Good enteral absorption, plasma half-life 12 hours, better gastric tolerability. It does the affinity for CYP3A4 enzyme, unlike erythromycin, is lower, so drug interaction chance is lower, but caution should be exercised. Thus, it is an alternative to erythromycin for respiratory tract infections, for ENT infections, skin and soft tissue infection, and genital tract infections with similar efficacy as that of erythromycin. Coming to the Clarithromycin, antimicrobial spectrum similar to that of erythromycin. In addition, the antimicrobial spectrum include Mycobacterium avium complex and also include other atypical mycobacteria, Mycobacterium lepri, and even some anaerobes, excluding Bacteroides fragilis. It is more active against Helicobacter pylori, Moraxella, Legionella, Mycoplasma, and sensitive strains of gram-positive bacteria. It is more acid stable than that of erythromycin. Food delays but does not decrease the absorption of the drug. Now, it has got slightly larger tissue distribution compared to erythromycin, metabolized by saturation kinetics. What do we mean by saturation kinetics? Saturation kinetics means as the concentration of the drug in the body is increased, the metabolizing enzyme gets saturated and the drug level in the body rises exponentially. This basically Clarithromycin, they are metabolized by saturation kinetics. So, the plasma half-life is around 3 to 6 hours at lower concentration. That increases to 6 to 9 hours at higher doses. No dose modification is needed in liver disease and mild to moderate renal disease. Clarithromycin is indicated in, like erythromycin, upper and lower respiratory tract infection, ENT infection, whooping cough, atypical pneumonia, skin and soft tissue infections. Now, they are also included in triple drug regimen to eradicate H. pylori infections. Okay. So, H. pylori eradication therapy তে কোন কোন রেজিমেন আছে? H. pylori eradication regimen এ কোন কোন রেজিমেন রয়েছে? There is a triple drug regimen, quadruple drug regimen. It is used as a component of triple drug regimen. It eradicates H. pylori in 1 to 2 weeks. It is also the first line drug in combination regimen against the Mycobacterium avium complex infection in AIDS patient, and also used as a second line drug therapy for other atypical mycobacterial disease as well as leprosy. Now, gastric tolerance is better. Higher dose cause reversible hearing loss like that of erythromycin. It can also lead to, certain cases have been reported, of pseudomembranous colitis. Which organism causes pseudomembranous colitis? It's Clostridium difficile. So, few cases of pseudomembranous enterocolitis, hepatic dysfunction, rhabdomyolysis are reported. Its safety in pregnancy and lactation is not known. It inhibits CYP3A4 and drug interaction potential is similar to that of erythromycin. Coming to the next drug, azithromycin, very commonly used nowadays. Azithromycin, it has got expanded spectrum of antimicrobial spectrum, improved pharmacokinetics compared to the erythromycin, better tolerability and drug interaction profiles. It is more active against, compared to certain other macrolides, it is more active against Haemophilus influenzae, less active against certain gram-positive cocci. High activity exerted on the respiratory pathogens like Mycoplasma pneumonia, Chlamydia pneumonia, Legionella, Moraxella, Campylobacter, Chlamydia trachomatis, Haemophilus ducreyi, Calymatobacterium granulomatis, Neisseria gonorrhea. However, the organism which are resistant to erythromycin, they are also resistant to azithromycin. Penicillinase producing staph aureus, which are not inhibited by penicillin, that can be controlled by azithromycin, but they are not active against methicillin resistant staph aureus, and they have got also good activity against Mycobacterium avium complex like that of Clarithromycin. They are acid stable, rapid oral absorption, larger tissue distribution and intracellular penetration. Concentration in most tissue exceeds that of the plasma. Terminal half-life is as large as more than 50 hours because of slow drug from the tissues. Largely excreted unchanged in bile, renal excretion is only 10%. Now, coming to the uses, azithromycin are the first line drug for number 1, Legionnaires pneumonia, 2 weeks treatment is required. Chlamydia trachomatis, a single dose 1 gram of azithromycin is needed for it. It can be used in non-specific urethritis, genital infections, trachoma, lymphogranuloma venereum, chlamydia pneumonia. Donovanosis caused by Calymatobacterium granulomatis. Azithromycin can be used, as well as doxycycline can be an alternative. Chancroid and PPNG urethritis, single dose is curative. The other indications include pharyngitis, otitis media, sinusitis, pneumonia, acute exacerbation of chronic bronchitis, streptococcal and some staphylococcal, skin and soft tissue infections. In combination with at least one drug, it is effective in the prophylaxis and treatment of the Mycobacterium avium complex disease in AIDS patient. Other potential use in multi-drug resistant typhoid fever, in typhoid patients where the safety reaction cannot be used, and in Toxoplasmosis. Side effects are mild gastric upset, abdominal pain, less than erythromycin, headache and dizziness can be seen. Generally they do not affect CYP3A4 enzyme, so drug interaction chances are lower. Coming to the next drug, Spiramycin. Spiramycin is another macrolide, although used only sporadically. It resembles erythromycin in pharmacodynamic and pharmacokinetic properties and in antimicrobial spectrum. Now, the special advantage with the drug is that it limits transplacental transmission of Toxoplasma gondii in pregnant mother. So, as a result, it is used in pregnant mother to prevent Toxoplasma gondii passage via the placenta in pregnant women and to avoid recurrent abortion. The side effects, other indications are similar to erythromycin. Side effects are gastric irritation, nausea, diarrhea and rashes.